not going to spend much time. I'm not going to spend much time at all. So just to begin. Now this thing won't move. Why is it not moving? Oh yeah. So just a very brief recap here. So just in terms of seizure types, you're probably all familiar that there is some children will experience focal onset seizures and some will experience generalized onset. And in terms of focal onset seizures, it's a seizure where the discharges causing the seizure begin in one particular area. And as a result, some children could be aware during these events. So you can have what would have been traditionally known as aura, but are now termed focal aware seizures. And in that, a child can be very aware of that something is happening. They can also have focal onset, which has impaired awareness, so they may not be aware during that one. And in addition, then you can also have motor or movement as part of it. So we may all be familiar with autonomisms, where some people might close or might smack lips. You can have ones where your tone is lost, so the child would fall to the ground. You can have that clonic movement, that jerking movement that we sometimes see with seizures. And obviously spasms is something that we associate really with tuberous sclerosis complex. You can have quite hyperkinetic movements, myoclonic jerks, or tonic seizures. And they can all have a focal onset. In addition, then you can have non-motor, where there's no movement involved. So you may just have an acceleration of your heart rate, autonomic changes, or behavioral arrest. And you can also have changes in your cognitive or emotional or sensory behaviors. And then for some people who have focal seizures, they can go on to have what we call secondary generalized seizures, or focal to bilateral tonic-clonic, which is your traditional tonic-clonic seizures that we're aware of. In addition, then again in 2017, the classification for generalized onset was identified, and again in generalized onset seizures we see a combination. We can see tonic-clonic, which is your very traditional stiff, then jerking, clonic movement where you just have the jerking movement, the tonic where you stiffen, myoclonic, you might be familiar with little myoclonic jerks, atonic seizures, which also might be called drop seizures, and epileptic spasms. Again, spasms being very much associated with this. And then you can have different types of absence, typical, atypical, or some with kind of a myoclonia, or a movement of the eyelid, or a myoclonic where they actually have a jerk with their absence. And then in some cases we have an unknown onset. So if we have a normal EEG and we don't have good videos, we may not really know where the seizure is coming from. And in that situation, we would tend to try and choose medications that kind of cater for all epilepsy types, and we have quite a number of those. So that is just a breakdown, and as I said, I'm sure you're all very familiar with that. I suppose from a paediatric point of view, one of the things I get concerned about is there's a lot of seizure mimics. So when we have children coming in on the first presentation, just because something looks like a seizure or just because somebody jerks in an event does not mean it's definitely a seizure. So we try to be really careful around this, because you don't want to diagnose somebody with epilepsy and with seizures and put them on treatment if that's not correct. And I suppose just to give a little bit of insight, if you're attending neurology or your epilepsy nurses and you're getting frustrated because you're saying they're having seizures and you feel we're not listening to you, this is a kind of a broad spectrum of stuff I see on a day-to-day basis, which is referred to me as queried seizures and don't have an epileptic basis. So all these conditions mimic seizures, but none of these would actually respond to our anti-seizure medication that we use. So for some children, they have, if they experience something they don't like, they can collapse to the ground, they go quite off colour, and they can have a little bit of jerking as part of that. And that's all in the history taking. That's, there's a little event at the beginning where the child becomes upset, even for like a millisecond. And the same with breath holding spells. I have children who are very strong-willed and they will actually hold their breath and knock themselves out, and they can have stiff and jerking as part of that. I have loads of teenagers coming in with vagal syncope, including my own daughter. So when she faints, she will jerk and she looks like she's having a seizure, and she'll have that guttural noise and the eye rolling as part of it. So clearly when you see that, it looks like a seizure, but it's the story before and after that really helps us differentiate between both. Obviously, if you've got long QT and cardiac syncope, again, you can have stiff and jerking. I get no end of children with daydreaming spells coming into me. think teachers in particular seem to raise a lot of concerns about children who stare, particularly if they have an underlying genetic condition that makes them at a higher risk of developing epilepsy. I get lots and lots of children referred my way. And again, it's all back to the story again in terms of daydreaming. We try and get parents to interrupt the event, and we see if the event interrupts the child, and that helps us to try and distinguish whether it's seizure or not. Lots of children, particularly kind of the 1 to 2 year olds, will have self-gratification. And again, they'll have movements which kind of looks like seizures, and lots of children who's already got a diagnosis of epilepsy may kind of start self-gratification, and they can come to me saying, oh, they're having seizures now again, after being controlled. So again, videos are really helpful. There can be behavioral episodes that mimic epilepsy. Panic attacks can mimic epilepsy. And then we have lots of people who functional neurological disorder, either in addition to epilepsy or independent of epilepsy. I spend most of my life looking at children sleeping, and often what they're doing is having benign sleep myoclonus, which again is little movements in sleep or little jerks in sleep. And particularly if a child has already a diagnosis of epilepsy, parents tend to be watching everything, understandably, but sometimes picking up on things that are normal childhood movements in sleep that become concerning for them. And again, night terrors and hypnagogic jerks in sleep, we often see them. So I get lots and lots of videos of children sleeping at nighttime with all these different jerks and events that we try and differentiate out. And then tonic up gaze. So again, in the small children, we have these events where the child will come with these very frequent upward eye movements, and it's benign tonic up gaze. And it looks very much like seizures because the eyes roll and they have a second or two where they don't respond during them. But again, we know they don't have an epileptic basis, so they don't respond to our anti-seizure medication. So I suppose what I'm trying to show there is just, it can be quite frustrating and difficult for both families and ourselves, really, just trying to tease things out. So sometimes if we keep coming back looking for more information or videos, it's not that we're trying to be difficult, it's just we know there's so many things that mimic epilepsy, and the last thing we want to do is put your child on medication that might cause adverse effects that isn't going to treat what the actual presentation is. So then just when we are diagnosing and treating seizures in children with tuberous sclerosis complex, so the first thing is to outrule seizure mimics. And how do we do that? So video. I can't say it enough. I tell parents, I spend my entire life just sitting looking at videos of children. And I suppose one of the things I often get are videos in the pitch dark. So I suppose we often kind of give some practical tips, which it's very straightforward. Most people, would know this, but like turn on the light, pull back the duvet if they're in bed at night time, make sure their pajamas are still on, but turn on the light so I can actually see what you're seeing. And we would have a lot of work. We do a lot of work at schools as well and respite centres, because if we can see videos of what a child is doing, we can often make that diagnosis much quicker. And I suppose in terms of infantile spasms that we associate with tuberous sclerosis, even this morning I had a 4-month-old baby come in. Mum had an excellent video. As soon as we saw the video, it was like, okay, this really looked like infantile spasms. And immediately that child was in EEG and got her diagnosis about an hour later. Whereas often if you've got somebody who's poor historian, without video, it can sound very different to the sinister thing that infantile spasms is. So often once we see a video, I think we're all so well prepared that if we see a video of infantile spasms, we pick up on it very, very quickly. But when someone describes it, it may not be as clear. And then I suppose just where does the EEG come into it? Because we know for some people with epilepsy, you can have a normal EEG. And we also know you can have lots of abnormalities in your EEG and actually not have epilepsy. So I suppose my indication for doing a standard EEG, we tend to do a standard one straight up. If I have a child with absent seizures, I'll pick that up on a standard EEG. So standard, I mean just by 40 minutes, child's awake, may not sleep, haven't been sleep deprived. Outside of absent seizures, EEG, standard EEG isn't always very helpful, and sleep deprived is much more helpful. So for instance, particularly with somebody with a history or with focal onset seizures, we get much more information when they're asleep. And the same with infantile spasms, it's that sleep piece that's really, really crucial. So if my concern is focal seizures or is infantile spasms, which are the two most common seizure types in children with tuberous sclerosis complex, I'm going to need to have them asleep. I'm not going to get the information I need unless they sleep during it. And then obviously I have lots of little people who come in who find it difficult to fall asleep. So we have ambulatory studies. So that means you put on the EEG monitoring and they can go home, sleep in their own bed overnight, and you get kind of 24 hours of EEG. So one, it helps if you have a child who won't sleep in a department, or two, if the child is having frequent events every day and we want to capture that event to say, yes, this is definitely a seizure, or no, this is definitely not a seizure. So ambulatory is really helpful in both of those scenarios. The issue in paediatrics with ambulatory is there can be quite a waiting list. So that can be a little bit frustrating, but generally, you know, if we need to get it done, usually if we have a good question, usually it's done kind of in a timely fashion. And then obviously video telemetry is used, particularly for children who maybe are candidates for surgery. So we do our video telemetry as part of that workup for neurosurgery. And I suppose, why is it important to know whether an event is a seizure or not? Well, first of all, if it's not a seizure, we don't want to be treating it with anti-seizure medication. So that's really important. And then to know what seizure types, certain seizures respond better to different anti-epileptic or anti-seizure medication. So we have certain genetic conditions, certain seizure types that respond better to one medication over another. So that's why it's really important that we have that information, that we can treat the seizures appropriately for any given child. And then when we think about imaging, how do we consider which imaging to engage in? I suppose our gold standard is MRI scans. So MRI is the one that's going to give us the most information. And we would certainly always do an MRI scan at some stage on our little people who present with spasms or with any sort of concern around tuberous sclerosis syndrome or complex. The issue with the MRI scan is you have to stay still for quite a period of time. So for a lot of our children, they need general anaesthetic in order to have an MRI brain done correctly. And that can be kind of difficult, particularly for parents who are going through a lot of stress already, to be told that your child's going to be put under general anaesthetic to have this investigation done. Now, in our under ones, we have what we call kind of feed and wrap. So for a lot of the smaller kiddies, we get them to be quite tired, and then we give them a good feed and we wrap them really tightly. And often we'll be able to get an MRI scan done without a general anaesthetic. So we would always try that first in the under ones. In Crumlin, there's a facility to do it in the under twos as well. But once you get an older child, then it really is general anaesthetic necessary, because obviously if you move, it doesn't, you don't get the correct pictures. I suppose a CT brain we do in certain situations, particularly if it's kind of tumours that have calcification, they show up quite nicely on CT. However, having a CT brain scan does involve getting there's radiation involved in it. So if you're getting very frequent CT scans, you have to really weigh up the pros and cons to that, and whether you're putting your child at risk because of all that radiation. And then when a little person presents in the first year of life with infantile spasms, and our concern is around tuberous sclerosis complex, we would generally do renal ultrasounds, cardiac echoes. We do a full workup, trying to identify clues as to whether this is TF, and then obviously be able to manage that appropriately. And then genetics and metabolic testing is done routinely. And I suppose the reason why we would repeat, so in terms of imaging, obviously if a repeat EEG shows a lot of focal discharges coming from one particular area, we would often go back and re-MRI to make sure that there's nothing in that area that wasn't there before. That would be a good reason to repeat your MRI scan. And also in the first 2 years of life, so babies and little people up to the age of 2, your brain is still developing. So you're always going to have kind of immaturities and differences in the under 2 brain. So even if a baby gets an MRI scan at a young age, we generally repeat it after the age of 2, because at that stage all the myelination has formed, and you get a more accurate picture of what that whether there's any sort of developmental changes or issues with the brain. In terms of genetics and metabolic testing, we tend to repeat our genetics. Now we do whole exome sequencing, and in most cases we do trio exome sequencing, so we do both parents and the child, and we actually redo their genetics every 2 years, because genetics is moving at such a fast pace and there's so many genes coming to light that we repeat it on a 2-yearly basis, because we're going to pick up more stuff each 2 years that's passed. And then in terms of EEG or neurophysiology, the reason we would repeat that is if there's a change in seizure type, if we were trying to capture maybe a new event. If during the day there's a change in the child that might suggest that there's, seizures happening in sleep, or ESES, which is electrical status in sleep, we might repeat our EEGs in that scenario just to get that information and be able to treat that appropriately. So in terms of infantile spasms, which is, I suppose, something we see quite frequently in pediatrics, and we always think PSC when we see infantile spasms, they're very subtle. They're episodes of brief stiffening. There can be a sudden forward neck movement, and then their arms can kind of move outwards. They cluster, so they tend to happen for a couple of minutes at a time. They can begin maybe once a day, but then you can kind of see them increasing in frequency over time. They usually occur between in the first 2 years of life, mostly between 3 and 9 months, and they get quite upset. So you can see in the video the baby doesn't like what's happening, so they're having this subtle kind of jerk movement, but then they'll often cry. It's like they really don't like the sensation. And it happens most commonly when they're going to sleep or just when they wake up. So again, why it's so important in EEG to actually capture sleep. And it's diagnosed. There's a condition called, or there's an EEG pattern called hypserrhythmia, and that gives us the diagnosis of infantile spasms. And about 1 in 3 babies with tuberous sclerosis complex will develop infantile spasms. And then how do we treat it? So prednisolone is something we use in the general population. However, we know from research over the years that if a diagnosis of tuberous sclerosis complex is made within the first couple of days after infantile spasms have been diagnosed, Sabril is a better option. So we generally change them to Sabril or Vigobactrin if we identify that they have a tuberous sclerosis complex. Difficulty with Sabril is about 1 in 3 children who go on Sabril will lose their peripheral vision permanently. So that's a very difficult conversation to have with parents, that we're given treatment to try and stop these spasms, but by doing so, we are causing this adverse effect that's permanent. But when we weigh up the two evils, the visual impairment can often outweigh if we can get control of the seizures early on. Ketogenic diet, at the moment in Ireland, it's quite difficult to get access to the ketogenic diet because there is quite a significant lack of ketogenic dietitians across pediatrics. However, the research would suggest it works quite well. And I suppose for children who are susceptible to adverse effects from medication, anti-seizure medications, it can be a good alternative. Zonergan is one I think that's used a lot more in America, and we've had some consultants who have come from America over the last couple of years and have used it in clinically, and we've had some really, really good effect from that. I was talking to my colleagues about Veramus earlier today, so there is a number of children cross-site who are on that at the moment. They tend to be the bigger children, and there was some research into it about 2 years ago, headed up by Trish Hines in Crumlin, and about the implications of using that. And then we have an array of anti-seizure medications, which we can give you information on, but there are other anti-seizure medications that we use. And I suppose what's the issue if we don't get good control of infantile spasms? So the big issue obviously is you don't want children having lots of seizures, and particularly with infantile spasms, and that hypserrhythmia can impact their development. And I suppose there was a paper done recently that Claire shared with me that looked at whether you treated children before they developed spasms with Vigobactrin, did they do better cognitively? And I suppose what they found in that paper was that there was no difference cognitively, and there was no difference to whether they were refractory, if they developed refractory seizure types later on. It did show that their infantile spasms maybe started a bit later, or maybe didn't start at all. But in the long-term outcome, they looked up at cognition at 24 months, and there really was no difference between the two. But we still do our very best to try and get control of hypserrhythmia and trying to get control of infantile spasms. The other common seizure type we see with tuberous sclerosis complex is focal seizures, and I suppose focal seizures can look very different depending on where the seizure is originating from. So, for instance, I'd see lots of children with occipital lobe seizures. They would tend sometimes to vomit quite a bit. They'd have kind of prolonged staring spells, one-sided jerking potentially. Whereas if the seizure is coming from the frontal lobe, I see children who do very complex movements and might move around and pick up a bag of sweets and eat and do all sorts of very complex things. So focal seizures can look very different in different children. And yeah, I suppose that's why we kind of, videos are so helpful, because there's so many things that can look like a focal seizure. And again, having a video allows us to try and see if we can differentiate if it is a focal seizure or something else. And then just, I suppose, what do we treat focal seizures with? So the sodium channel blocker family, which is your Tegretol and your carbamazepine, oxcarbamazepine, they seem to almost irritate and cause infantile spasms to become more of an issue. However, when you get to the older child, and if they discover, or if they develop focal seizures, they do tend to be quite helpful. Lacosamide is another one we use quite frequently. Temple Street in particular are quite fond of this one. And I think it's really good because you can give it as an IV loading dose, so you can actually get control quite quickly. The family of benzos we can use, Keppra and Epilum, which I know Claire is going to talk a little bit more about. And I suppose Epidiolex is one of the newer ones, the cannabinoids, that has shown to be effective enough to actually justify it being prescribed for people with tuberous sclerosis complex. I've had mixed responses to it so far. I have children with the SEN1A epilepsy that have done quite well, but I haven't had as good a response in a small number of tuberous sclerosis patients. And the side effects, in particular, kind of the gastro side effects, have found to be really challenging to manage. But look, it's an option out there, and for some people, it's going to be worthwhile trying. And then Topamax is another one. So there's 20-something different anti-seizure medications, and we try and tailor them to the child themselves and the potential side effects they may cause. For instance, Topamax can cause you to lose weight. So if we have a very underweight person, we're not going to be too enthusiastic about going straight to that. So trying to kind of work out what potential side effects each medication has, and whether that would be a positive or a negative side effect if the person was to experience them who we're treating it with. So that's really, I suppose, how we choose our anti-seizure medications. And then I suppose there is always the problem that, obviously, particularly in tuberous sclerosis complex, it can be very difficult to control seizures. And we know that. And we know there's quite a high percentage of people who won't respond to anti-seizure medication. So Claire's going to talk to you a little bit more about those people. They're going to end up going into adult services, so having kind of looking at options to manage your epilepsy, whether it's new medications that have since been kind of come on the market, or alternative surgical or dietetic options. So I'm going to hand over to Claire now, and she can go ahead and do her part, and then we'll be available for questions afterwards. Okay.
Thanks, Anne. I will try and share my screen. I think
I've stopped sharing there, so
I think you're a host now, Claire. Yeah, hopefully.
Yeah. I think I've just lost I had it lined up, but technology. Sorry. Okay, I think this should work now. Apologies. Okay, so hi everyone. I'm Claire. I'm AMP in epilepsy in St. James's Hospital, and I suppose kind of sitting back and listening to the paediatric story and side of things really just hits home how complicated epilepsy and TS is, and that's just the epilepsy part of it. So yeah, it's definitely tricky to get a diagnosis and then moving forward with treatment. So thanks for the insight onto the pediatric side of things, Anne. So I'm going to change tack just a little bit, and I'm conscious of time, so apologies if I fly through the slides, but really it was to have a resource. I know that Epilepsy or TSC Ireland will make this available on their website, so there'll be lots of resources, and I mightn't go into everything into too much detail. But just to give a nod to the TSC guidelines that were developed in the UK, these are really what we are using at the moment to manage care for TSC patients in St. James's, and I think that's across the board. There are also a US version, but this is what we're using in Ireland. They're very similar. And then in terms of epilepsy care across the country. These are the sites that we have epilepsy centres with neurologists and epilepsy nurses, both clinical nurse specialists and A&Ps working in. And there is also, just let me know before we started, that there's also a paediatric centre now in Galway. And we have 3 paediatric centres in Dublin. So I suppose this was the development of the epilepsy clinical care programme back in 2012 to try and disperse the expertise across the country. So no one is too far from an epilepsy centre, ideally. So I suppose just thinking about transitioning into the adult services, a lot of people with TSC will transition over into epilepsy services because they still have a burden of seizures. And whether that's well controlled or not, they will continue to need ongoing care. And transitioning into adult services from epilepsy wise is no one seems to have really cracked this nut. And we were at a conference recently, and transition was a big focus. And again, there are lots of individual pop-up transition clinics or services. They look very different from each other, but it's really not a nut that's been cracked well in the epilepsy world, and we continue to work on that. And this is just, I suppose, looking into the literature at that, and this was a systematic review of transition care. And while it was found to be of benefit, we have a lot of gaps in our knowledge about how best to run that. In terms of St. James's, we run a meet and greet. We work very closely with our paediatric colleagues and have a really good network across the country. And we tend to get lots of the information that we need to get when young adults are coming across to us. But yes, so we run a meet and greet. Sorry, I lost my train of thought. We run a meet and greet in St. James's, and really that's just to introduce people to our hospital, the staff, how we do our business, because it can look very different to what's been happening in the paediatric world. And it's just, I suppose, kind of a warmer about what might happen as you move forward into the adult services. If anything else, just to orientate you to the terrible parking situation for future appointments. But I guess a couple of things that are really important in terms of your young adult transitioning into adult care. These are some of, I suppose, the goals that we should have, that our young people understand their diagnosis, they understand their seizure types, what their particular triggers are, their medications, how their lifestyle affects their epilepsy, and what they should do in an emergency and where to get help. And ideally, this would kind of be addressed as they're coming through into the adult services. And if a young adult can sit down with me on the first day we meet and tick off some of these boxes and tell me about their epilepsy, then I think they've had a really successful transition into adult care. And that's never complete, and we wouldn't expect it to be complete. But if they're achieving some of them, that goes a long way for kind of that independent care as they move into adulthood. I'm not going to go through this, but there are lots of really good transition resources on the reputable epilepsy resources that you'll find on the internet. And this is one I really like. It's Epilepsy Space, and it's designed by young adults for young adults. And they give some really nice tips about how the whole process can go a little bit smoother. In terms of what we want in the adult world, it's not really complicated and technical, and some people will arrive with a folder that's full of every investigation that their young person has had done, and which is wonderful, and we love lots of information. But in terms of really getting to know how epilepsy has affected the life of our patient, we want to understand the journey. And it doesn't need to be complicated, but there are important points along the way that we like to know about. So in particular, how it began, how it's been going. Have there been periods of seizure freedom? If so, what were the medications during that time? What were the doses? If there were any side effects, what were those side effects and at what doses? And really that's about exhausting medications. That list, when you come into a refractory type epilepsy, we can go through them pretty quickly. So it's really important that we think about how we have tested the medication. Has it been adequately therapeutic dose before we kind of put it in the bin and say, no, that one didn't work. In terms of any type of epilepsy, but specifically in TS, we know that seizure semiology that can change. So what looked like a seizure, for example, the infantile spasms Anne talked about, can move on into focal types of epilepsy. And it's really important to explain to us what the seizures look like and what you call them. So some people describe seizures in terms of the seizure the semiology and the classifications that are very kind of technical words. But we still hear people talking about petit mal seizures, which was a long time ago in terms of our terminology. So I don't encourage people to use tonic-clonic, absence, use whatever seizure name you want. So often people say the big one, the little one, that's fine, as long as we know what you're talking about. So my big one looks like this is how I feel beforehand, this is what it looks like in between and how I feel afterwards, versus my little one is like this. And once we're on the same page, once we know what we're talking about, then we can treat them adequately. Really important, again, about seizure frequency, seizure diaries. When it comes to our medications and how we're going to titrate them, we don't have a crystal ball. We can't look into the future and say this one will work or it won't work. You're going to have a side effects. You won't. Unfortunately, there's lots of work being done on which people might have side effects to certain drugs. But for now, we don't have that. So really important that we know what seizure frequency, seizure severity, recovery time, what that looks like before we try a medication. And then when we introduce a medication, how that looks and compare both. And when you see it in black and white, so and I won't mention seizure diaries again, because I know people who have a chronic epilepsy and some of their kiddies and young adults may have a huge burden of seizures, and to write everyone down is utterly painful, and I completely understand that. But sometimes, depending on what's happening in life at the time, seizure severity, seizure frequency can seem much more burdensome. So if there's other things going on, then seizure frequency can seem like, oh, the epilepsy is really bad at the moment. And that's happened time and time again in clinic, where I've sat with people and seizures are really awful. And the seizure, when we look at the seizure frequency, it hasn't changed. That doesn't mean the seizure isn't worse. It may be that their seizure severity is much worse, or the recovery time is much longer. But it's really important that we kind of have that black and white, that we can review it together. So seizure diaries are super important, even though I know that they are absolutely painful. We like to know about your investigations, what you've had in the past and the results, and really importantly, for us to have any sort of therapeutic relationship moving forward, we need to know what your priorities are, what your goals are for your young person, and what their goals are. Is seizure freedom top priority above all else? Or are we thinking about lifestyle, being able to hold down a job, and how to manage side effects? So understanding what your priorities are, and for you to let us know what they are, is really important for us all to move forward. In terms of the adult service and epilepsy, our priorities changed about information that we need to give to you. So and I have new diagnoses here, which might seem a little bit strange in TS, but we do see some patients coming to us with their first seizure and they have a diagnosis of TS, and their epilepsy has only started in adulthood. But essentially, we're looking at chronic disease management. And so over the lifespan of someone, their priorities will change in terms of the information that they need. So things that we might have to talk about adolescents with, we might not have had to talk about young children with. So for example, contraception, thinking about planning pregnancies, thinking about the medications that we're using around pregnancies, driving restrictions, alcohol, drug use, all of those kind of things that we didn't have to think about when our children were younger are things that we need to think about as they move into adulthood. And these are conversations that we start to have with our young adults. One of the things I just want to highlight in terms of conversations that we have are seizure triggers. And I suppose these are something that you would have been addressed with you guys during your pediatric care, but seizure triggers can change. So knowing what your triggers are really important, but obviously you mightn't have had to think about alcohol in terms of seizure triggers previously, but this then will start becoming an issue with your young adult, and understanding their tolerance and how it affects their epilepsy is really important. So for them to be able to kind of have that open conversation is something that we'd really advocate. And things again like menstruation and hormone changes, medication that they might take for contraception, all of those things can alter what our seizure triggers look like. Just to mention valproate, it's an excellent drug. I'm sure lots of you are aware of it. The considerations again change as a child moves into childbearing age. And that's considered from the age of 12 until 51 is what is covered as childbearing age. There is a pregnancy prevention program that's ran by that's recommended by the HRPA, and it's ran by the HSE. And this is essentially to prevent pregnancies that have complications or births that have complications. We know that epilepsy can cause issues with children in terms of developmentally, both physically and cognitively or neurodevelopmentally, in about 40 to 50% of cases. So we're really, really careful with this medication. It doesn't mean it's not an excellent medication. It's just we need to use it with caution. And sometimes we have people on this medication who are of childbearing age because it works for them and they're not planning a pregnancy, and we just take the appropriate steps to prevent the pregnancy from happening. And there are considerations with men and fertility that is just really very new information that we also, their conversations we have to have with our male patients as we move forward as well. And then I suppose thinking about what epilepsy and TSC specifically looks like. And this is different from our general population with epilepsy. And when you go onto some of the general epilepsy websites, there'll be things quoted like 2/3 of people become seizure free on their first medication. That's not the case with TSC. And this was, this is an old publication. It was done in the US, looking at the natural history of tuberous sclerosis in terms of epilepsy. There were 291 patients. And there's lots of, it's a busy slide, but essentially 37% had a history IS, infantile spasms, 85% have a history of seizures, and then it goes on and on. But I suppose what I'd like to draw your attention to is 62.5% developed refractory epilepsy. So that's epilepsy that's difficult to control, and people continue to have seizures once they've been trialed on 2 or more medications, and 33% achieved remission. So this kind of flips from what we see with our general epilepsy. And that's not just specific to TS. There are lots of conditions that will have a higher percentage of development or of refractory epilepsy. And TS is one of those cases. This is a study that was done that kind of updated, though that was 2010 previously. This is an updated version in 2021, and essentially I found very similar results. It was a big cohort, 257 adults, but again, it found similarly that we're seeing 2/3 are drug resistant and 1/3 become seizure free. So just to remind everyone, lots of words that we use to describe this: intractable, refractory drug-resistant epilepsy is failure to respond to appropriate drugs at the adequate doses, which is important that we're trialing our doses to a therapeutic range. And once we start failing medication, we have about a 10% chance of responding to a third agent. So the efficacy of our medications start dropping off very quickly when we get to this stage, and it makes for a much more longer and complex trajectory. And then there are other things that we need to consider that I'll talk a little bit more about. Who will develop drug-resistant epilepsy? A question that we're asked very regularly. And again, no crystal ball here, but there have been some really nice studies that have been done to try and look at this. And there are lots of studies that are being done in terms of biomarkers and what's the difference between someone who responds to medication versus someone who doesn't respond to medication. Again, we still haven't cracked this nut, but this was a systematic review that looked at drug-resistant epilepsy, and the 3 factors that were found that appeared to significantly increase drug-resistant epilepsy was TSC2 mutation, infantile spasms being present, and a high number of cortical tubers. And that wasn't found in every study. The cortical tubers previously were believed to not have an impact on your burden of epilepsy, but this particular work showed that it did have an effect. And how we identify people at risk. So we continue, as Anne had talked about, MRI and EEG monitoring, and additional monitoring when things start changing, or genetic testing, and then close observation of the children with early onset of seizures. So what do we do? What's our treatment? So first line is anti-seizure medication. Again, won't dwell on this, but really I just wanted to highlight how some of our medications will work in different ways. Some of the medications, we're not sure exactly what mechanism of action they have. But I suppose something that we're thinking about as epilepsy practitioners when we look at medication that our patients are on is what type of medication is in, where is exactly it's working, and whether or not we need to add in a similar medication because we're getting efficacy with that medication, but we're just not fully there yet, or whether we need to change tact and have a combination of medications that work differently. So that's really just to give a nod to some of the decisions that we make may not seem like first line, second line, but it might be that we're introducing a different type of medication. When we think about mTOR inhibitors, and I'm sure this group of people have heard of mTOR inhibitors. Everolimus and sirolimus are the medications that have been developed. Most of the work has been done in terms of TSC and everolimus, and this is just some of the information that has come through the trials. We've had phase 1 and phase 2 trials with patients with TSC and seizures. The mTOR inhibitor, I should say, is used for other indications with TSC. So when it comes to TSC, we know that mTOR inhibition is essentially switched off. TSC1 or TSC2 gene aren't working correctly, and we have this overgrowth or uncontrolled expression of mTOR, which is what leads to these tubers or renal lesions that we see across the whole body in the different systems. In terms of managing it for epilepsy, we tend to need a higher dose for these mTOR inhibitors in comparison to for renal manifestations or cardiac manifestations, and using it for epilepsy versus management of a SAGA or some of the TSC manifestations we see in the brain. Again, we tend to need a higher dose. There was an EXIST-3, so a phase 3 trial with everolimus and TSC. This was called the EXIST-3. And there were some positive results with these. And essentially, and this was a really nice paper that looked at one of the things that we always wonder about, I suppose, in clinical practice is these trials tend to be short. So you can see a 12-week period, a 6-month period, but really we're thinking more long-term. And some of the trials end by then. And this was a very recent paper that looked at the extension of the EXIST-3 trial. So when patients were invited to stay on the medication and what that looked like. And really the
I think we've lost Claire, have we?
It looks like it. Claire, I think we've lost you, have we? I wonder, can she see us?
Yeah.
Let me see here now. Let's see.
Hi, sorry, did my internet connection went?
Yes.
Apologies. Must have good old Wicklow internet. Sorry.
No, that's fine. I was just trying to figure out what to do.
So can you see my screen now?
Yes, yeah. We can
Okay,
see now.
great.
Great.
So
Thanks.
just to say about the mTOR inhibitors, it can be a difficult treatment to manage. There are a lot of side effects with the mTOR inhibitors, and it is it's an immune suppressant. So we can see things that like very bad oral issues and development of pneumonia. So you can have quite serious side effects. And in the particular EXIST-3 prolonged phase, there were 4 deaths. 2 weren't related, thought to be related to the treatment, and one was pneumonia and another was a septic shock that was felt to be treatment resistant. So they're not without side effects, and it needs to be considered whether that is something that is going to work for someone or not, and weigh up the pros and cons, much like a lot of our medications. And we need to think about having, before you go in an mTOR inhibitor, that we need to do bloods, and also have records of vaccinations are really important. Just to talk a little bit about cannabidiol, this is just taken from a paper, reference below, Elizabeth Thiel from Mass General, the Hirschkopf Centre in Mass General, one of the biggest TSC clinics worldwide, and this clinic has a huge amount of experience in managing TSC. And this was looking again, this one is particularly interested from a clinical point of view because it's gone beyond the clinical trial phase, and this is long-term treatment for seizures in patients with TSC. And to orientate you, the light blue box is at 25, less than or great equal, sorry, greater or equal to 25% reduction, 50% reduction, 75 and 100% reduction. And then on the bottom, there are the weeks, so 1 to 12 weeks, 13 to 24. So if we skip down and look at weeks 37 to 48, so this is essentially 2 years on, and looking at what the percentage reduction is, we can see that cannabidiol in these patients, and the product that was used in this particular study was Epidiolex, and it was showing some good efficacy in terms of seizure control. There's been lots of talk about what the other potential effects cannabidiol or Epidiolex can have, and we would have lots of anecdotal reporting of better mood, less sleepy, and more behavioral benefits. And again, there have been case reports and small studies, but that's yet really we haven't looked at that as in depthly as we'd like to make great statements about it. But there is a very nice trial worldwide being ran at the moment called EpiCom, and that will hopefully give us lots of information in terms of the other potential benefits for cannabidiol. Similarly to Anne, we have about 60 people on Epidiolex in St. James's, which is a good cohort. And of those, our TSC patients are tending not to be particularly have impressive outcomes on the Epidiolex. But again, it's a small cohort. That's 60 patients with not with TS. So of that, there are 4 patients that were trialed with TS, but we've 60 in total, so some decent amount of experience with cannabidiol. In terms of the ketogenic diet, so just to give a little brief overview, and we are very lucky in St. James's that we have Laura Healy, who is the only adult dietitian who takes care of people on the ketogenic diet. And it's a national service, so she accepts referrals from everyone across the country of Ireland. So essentially, it's a high-fat diet. So your calorie distribution comes 75% from fat, 20 from protein, and 5 from carbohydrate. And again, in TS, we tend to see this working quite well. To orientate you to this slide, this was a systematic review that was done in China, and it was over a 10-year period looking back at clinical notes, so a retrospective review, 53 children were included over 10 centres. And then it looked at how long they remained on the ketogenic diet and how effective that was. So if we just look at the bottom line, at 12 months, there were 16 patients left from the 53 children. So 31%, so a third remained after 12 months. 13 patients or 25 had this 50% or more reduction in seizure frequency. And that's a real measure that we use in our clinical trials, this kind of 50%. So if your seizures drop by half or more, then that's kind of a measure that we use across all our different medications that are trialed. And then 5% were seizure free. So that's just kind of a look. And again, as Anne said, we see more favorable results in ketogenic diet in people with TSC. Epilepsy surgery. We're not doing a lot of epilepsy surgery for TSC in Ireland. It is becoming something that is, in terms of conferences worldwide, is talked about a huge amount more, and it's certainly happening. Professor Colin Doherty, who's a neurologist at St. James's, who worked in the Hirschkopf Centre with Elizabeth Thiel in Boston and has a huge experience with TS, would kind of describe the thinking behind epilepsy surgery and TS as kind of this whack-a-mole scenario. So you take out one tuber that's causing these abnormal discharges and then your seizures. And once you have that one out, then another one becomes active, and you kind of have this scenario that, you know, you keep needing to scoop out these tubers. Having said that, we're seeing now with these kind of papers like systematic reviews looking at epilepsy and surgery that really is a worthwhile option in terms of at least investigating for patients who are have drug-resistant epilepsy. And again, this shows of 46 studies that there was a good reduction in seizure frequency. With any of these, none of them are a magic wand. And I suppose that's one of the things that we need to do when we are in clinic with people, is setting expectations, and for you guys to be able to communicate your expectations of the epilepsy and care and treatment, and where we are and what we're going for and what our goals of treatment are. But again, really important that you're aware of the possible treatment options and for them to be explored with you as well. In terms of epilepsy surgery, it's not as straightforward like everything with epilepsy. There is a whole pathway, and the National Centre, there are 2 centres in Beaumont and Cork, and we would refer our patients to there, and they go through a series of investigations and then they're discussed at a multidisciplinary team meeting and a decision made. And that may be to have a resection of some sort, so brain surgery, and then the removal of a particular abnormal piece of tissue that's causing epilepsy, or a VNS, which is a vagal nerve stimulator. And again, I won't go into this in great detail because I'm really conscious of time. But again, it's something to be explored if this is where you are with your epilepsy and seizures. So that's me, and thank you for listening. And I know we're short on time, but we'll be happy to answer any questions for a few minutes after 8 o'clock. I'm speaking for you now, Anne, as well.
You're on mute, Emma. Can you hear her, Claire?
No, you're on mute, Emma.
Emma, you're on mute.
Oh.
Sorry, apologies.
Oh, right.
That's so annoying when people do that. So I was saying thank you very much for those very interesting presentations from Claire and Anne. If people are happy to hold on for a couple of minutes, we have a couple of questions in the chat, and then maybe if anyone wants to ask anything else, if they want to unmute themselves and raise their hand. So we had one for Anne. Why do you repeat genetic testing every 2 years? Is this because the mutation has not been identified?
Yeah, so I suppose it's in the general population that we see presenting with infantile spasms.
Okay.
Not specifically for the TS community. But I suppose the labs we use, which are based in Germany, would suggest that you repeat it, because obviously there's so many new genes coming about, and sometimes a genetic, something that might tell us what medication might work better. So particularly for the sodium channel genes, etc.
Okay.
So that's the rationale behind it.
Right.
Yeah.
But for TSC, generally, once they've identified the gene, that's it. They don't need to.
Yeah, unless there's a change in presentation that might suggest a second gene is at play.
Okay.
And that would be a reason why you'd repeat it maybe in that scenario.
Perfect. Thank you. And then, in your opinion, what are the underlying causes of the refractory nature of seizures in many individuals with TSC?
Claire, do you want to handle that one?
That's a big question.
That's a very good question.
Oh, well, I suppose when we think about TSC and exactly what's happening, we have a genetic cause for this overgrowth of the mTOR pathway. So we're having these from birth, the manifestations that you see in TSC are developed in the fetus. So during all of that neuronal development, we are getting these overgrowth of cells, and and that's where we see the tubers. But your tuber count is what you're born with. It doesn't change over the course of your life. Having said that, the tubers themselves change. So they can get bigger, they can calcify, and they can block areas that are really important. The refractoriness of TSC and epilepsy and, the refractoriness of TSC is probably something to do with that mTOR pathway in terms of it's a multifocal disease. So we're not seeing just one particular lesion. It's not a type of epilepsy that you sometimes see with focal epilepsy, that it's a cortical dysplasia that can be treated very easily with surgery. It's a much more complex situation. And I think that goes for the whole nature of TSC in terms of being a multi-system disorder. I imagine there's something further down in the genetics that we haven't understood about how we treat it. And I think that will come in time. I know that's probably not helpful for people who are dealing with the here and now. But I do think down the road, we will understand how to treat it better when we understand the genetics and exactly what pathways are at play.
I agree, Claire. I think even if we look at other genetic causes for difficult to control epilepsy, such as your SCN1A Draves, I think genetics is moving at such a pace. And I suppose we're trying to target now. So by knowing the genetics and getting down to the depth of what gene is involved, it can really help us with kind of decisions around treatment and whatnot. But I suppose we do know even genetics that don't involve tuberals can have very difficult to control epilepsy. So there's definitely a genetic component that affects the wiring of the brain and probably makes these epilepsies really difficult to get control of. But I think we are progressing, but yeah, not at the rate we'd probably like to.
No easy answers there. Another question's come through. Just how do you know if peripheral vision is affected versus child's cerebral? Yeah.
So just what we would normally do in Tala is we obviously before starting we would have ophthalmology, a baseline of what vision is like, so they would see ophthalmology straight off, and then I suppose as the children grow, we try to make sure the cerebral is the lowest dose possible that will work for the child, because we know there is a connection with higher doses. But what we would normally do is then we would review on a regular basis. So I had a little girl last week who had been on cerebral up to 18 months ago. So she had her final ophthalmology. Now she's not TS, sorry, but she was on cerebral for infantile spasms. But she had her final ophthalmology review this last week. So that was 18 months after cerebral was finished, and there was no impact on her peripheral vision. But really, we would always, we would schedule kind of review of ophthalmology during the period of time you're on treatment, and then even afterwards for a period of time to see if there's been any deficit after you wean and kind of come off the treatment.
Okay.
And generally, I think
sorry.
I think generally in a lot of the the trials that have been done, the issues with the vision are seen very early on in the treatment.
Okay.
It doesn't mean that that then it's reversible, but it's generally seen early. So if you're not seeing it within the first few months of the medication, then you usually won't have a problem going on.
The only thing is it can be quite tricky to assess the smaller child. So there can be kind of, you know, that can be a little bit tricky as well. But yeah, you're right. I think you probably know early enough if there's going to be an impact on your peripheral vision. And you have to remember it is just your peripheral vision. So, you know, it doesn't impact kind of what you're seeing. But, you know, it can impact obviously getting a driver's license at a later stage, but it doesn't cause a full visual impairment. It's peripheral vision.
Thanks for that. That's all the questions in the chat. Does anyone else have a question they wanted to ask? I think you should be able to unmute yourself if you do. I have a quick question if I can. Just the ketogenic diet, and I know there's the service in James's. In terms of pediatrics, and you were saying it's quite limited and there's not a huge amount of staffing. What's the current situation? Is it long waiting lists, or
it is at the moment?
happening?
Yeah. So we have a service in Temple Street and just one in Crumlin. We're linked into the Crumlin service, so I think at the moment we have something like a 0.25 of a post. So and obviously there's a lot of work goes into putting somebody on a ketogenic diet. So it's weeks and weeks for the dietitian to actually identify, you know, a menu for the child and put everything in place and teach up the parents, and you know, because everything has to be weighed, everything has to be finished. So there's so much work involved that, you know, if you only have that small number of dietitian, it doesn't stop when you start on the diet. So for instance, if you have somebody who's on it a year and then maybe they're prescribed an antibiotic that has some carbohydrate in it, the dietitian has to go back and kind of cater for that. So it's very heavy work-wise, and at the moment has been a bit of a difficulty. Now there has been funding gone into it in the last couple of months, and certainly there has been a slight improvement more recently. But yeah, it has been tricky to get access. But hopefully things will improve, because as I said, I think there's a maternity leave that's coming back. And again, you have to be kind of specialised in the ketogenic diet. Not every dietitian is going to know how to kind of implement it. So that's been the challenges. But I do think it will get better. I think it's been identified as a big need within the epilepsy services for paediatrics. So I do think it is, and it will improve even more.
Well, that's good to know that there's improvement.
And I think one of the kind of tips for if you're at that stage and ketogenic diet has been mentioned, to start keeping a food diary can be really helpful, because that prep work is done as such. So when you do get the opportunity to sit down with the dietitian, you have that in front of you, because a lot of I know Laura likes to have a food diary done for at least a month in advance, if not longer. And really it's just to identify what types of food you eat, how is it working, and what's your current carbohydrate load, and how you kind of make that transition over to a more fat-focused diet. So to have, if it's been mentioned, start the food diary immediately.
Okay, thanks for that. It's a good tip. Anybody else have a question before we wrap up? Everyone else is quiet. Okay. I think we'll leave it there. We've gone a little bit over time. I just want to say again, thank you so much to Anne and Claire for sharing that your expertise and knowledge and experience of epilepsy and TSE. Lots of really useful information there in your slides, and we'll be putting the recording up on our website in the next few days so people can listen back, and because I know I didn't take everything in as it was presented there, but it's great to be able to review it and listen back and pick things up on a second viewing. So thanks so much to you both, and hope you have a lovely rest of the evening, and thanks to everyone who attended. And thanks to Laura who organised, Laura Enright, who couldn't be here this evening, so I stepped in as the incompetent host at the last minute. But thanks to Laura for organising this all, and wouldn't be here without her doing all the hard work. Okay, good night everybody. Thank you.
Thank you.
Thank you. Thanks very much. Bye. Thank you.
Bye.